Welcome students to R.A.T.S for pages. I shall be plunging into the topic proper, which is muscle biopsy. We shall see how a difficult topic can be made easy. Incidentally, the importance of it is given over here, including the chart, which can be kept for our exams. Think of the subheadings will take you to the answer. And for this particular topic, you find that these will be the subheadings. Try to have them in mind. This incidentally is a patient on a non-invasive ventilator using a remote control. Obviously, you find that the trauma of the disorder can be explained too very well by this picture. Normal things first. When we say muscle, we have got a smooth muscle, we have got a cardiac muscle, and we have got a skeletal muscle. This is about the skeletal muscle, which are ribbon-like, almost uniform, and a peripheral nucleus showing cross striations. And when they are cut across, I'll be able to get polygonal or hexagonal structures with the peripheral nucleus and a very thin limiting membrane and an interstitial space. Hardly any inflammation or fat. A nice saying. I believe the root cause of all evil is abuse of power. Since the muscle is about power, I thought I would take the quotes about it also, though it is a different power. Structure of the muscle fiber. Always an examiner says basic things first. When we fumble, they try to help us out by going to the basics, which is even more difficult. Look at this picture and let us see how we can trace the description. We have got a bone, tendon, and then the muscle. The muscle itself is being externally covered by epimysium, and the external part of the muscle is the perimysium. And these are the muscle bundles. The muscle fibers are here, and each one is a fascicle. There can be the septae over here. In the periphery, there can be blood vessels. The same thing, the muscle fiber is being magnified. When I say muscle fiber, earlier we had been talking about the peripheral nucleus, that is what it is. And these will be having the filaments, which are separated by the septae. They can be externally covered by the sarcoplasmic reticulum. The muscle fibers themselves can be containing the mitochondria. There are two types of it. One is a thin filament, another is a thick filament. And they are covered with the sarcomeres. This is a higher magnification of the same, worth drawing in your examination. Peripheral nucleus, you have got a sheath externally. There is a light and a dark band that can be seen. The cut surface shows the myofibril. Over here, multiple myofibrils are there. And there can be the mitochondria. Externally, there will be the sarcolemma. And when it comes to the individual myofibril, there is a sarcomere with the alternating light and dark zones, the H zone and the Z disc. And you find that there is a thick myosin filament and a thin actin filament. This will be the constitution which we shall be having in mind. This is rather an easy picture which I would like you people to fundamentally draw for any of the muscular dystrophies. What is the theme of this presentation? As I mentioned earlier, it is power. Nearly all men can stand adversity, but if you want to test a man's character, give him the power. You will know whether he is using it or misusing it. So this again is rather a schematic picture wherein I am finding the multiple polygonal or hexagonal muscle bundles grouped together, being covered by the perimysium and the epimysium, and there are insinuating septae over here. This is a higher magnification, and this is a trichome strain. And sometimes it has been well marked. So this is a individual muscle fiber that I am seeing. This diagram we had seen earlier, only for a recapitulation. Now, when it comes to a muscle biopsy, always it is a teamwork. And what is the team? It consists of the clinician, the processing laboratory, and the pathologist, the trio. The clinician, processing laboratory, and the pathologist. The ordering physician should orchestra. That means he should regularize the collection, packaging, enable the processing of the material, and repeat the biopsy if required. He should also be knowing about the cryopreservation and the enzyme histochemistry. So this will be the team that is there, and that is what the physician is supposed to be doing, instead of putting the onus of responsibility squarely on the pathologic pathologist. So this is a wonderful quote got from Wikipedia. Therefore, the ordering physician must orchestrate the collection, packaging, and processing of the tissues to ensure the desired testing can be performed and to avoid the need for a repeat procedure due to limited, inappropriate, or poor sample quality. This is the ordeal that we commonly face. Coming to the types of muscle fibers. So it is not very difficult. There are only two things, type 1 and type 2. That is why I have emboldened them. So they are based on the color, and the color itself is a reflection of the myoglobin. So in type 1 fibers, I find that the fibers are red in color because they contain more amount of mitochondria and more amount of capillaries. They have got a greater endurance and they are slow to fatigue. That means they can withstand the pressure for a longer time. Oxidative metabolism rather, leads to increased amount of ATP. So this is about the type 1 fibers. Increased myoglobin, you find that it is red in color, and there is greater amount of oxidative metabolism leading to ATP production. Whereas the type 2 fibers are white in color due to low myoglobin. Here it is increased, here it is low. And it relies on glycolytic enzymes. Enzymes which start somewhat using the energy of the muscle. This is a wonderful schematic picture which you people shall follow and repeat after I said. You find that there is a muscle bundle. I am finding dark fibers and then there are pale fibers. This is the way that it has been divided. Also, I find that there are two motor neurons, myelinated motor neurons, which are supplying this muscle bundle. They may be having a myelin sheath and then the Schwann cells, etc. But then you find that there are two fibers separating or rather supplying the entire muscle bundle. Sometimes there can be a denervation. So you find that one fiber has been cut off. Always we know that it cannot regenerate the neuromuscular tissue. It cannot regenerate as such. So when the nerve is cut, what happens is there is a compensatory proliferation of this muscle fibers, and these try to supply the entire bundle as such. And whatever is not being supplied, they undergo atrophy or even disappear. So this is the single nerve that is supplying the entire bundle that has been left here. If it is not clear, just follow this. These are the two nerves that I have been talking about. One has been cut, and this is the initial supply by the other nerve. It undergoes a proliferation, supplies all the muscle fibers, and as a result of which you find that they develop a uniform color. Look at the uniformity in the color over here and the variation over here. So the type 1, type 2, etc. might more be reflecting a neuromuscular pathology rather than a muscular pathology. So I given a tabular column, which I try to make it easy for the students. As I mentioned earlier, only two types of fibers, type 1, type 2. There can be the other subtypes of these. So these are the properties, these are the fibers. So certain important things we shall be remembering. The motor unit type is slowly oxidative in a case of type 1 fibers, whereas it is rapid in oxidation. The resistance to fatigue is high in type 1, whereas it is low in type 2, B or C. Glycogen content is low, whereas it is high in the others. And the capillary density is high in type 1 fibers. That is why it is red in color, I told you earlier also. So these are some of the differences. The same table is continuing. You find that in type 1 fibers, 3 M's I would like you to remember. Myoglobin, and then there is a mitochondrial density which causes a red color. So all of them are mauve in a case of the type 1 fibers, whereas it can be low and pale in a case of type 2C fibers. Alkaline phosphatase is low, whereas acid phosphatase is high. The corollary on the other side. So this much, if you people can remember, it is fine. So just a symbol to show that we are talking about the muscles, the dystrophy. This is a wonderful table. I had given it in another class of mine also. I would like you people to kindly read it repeatedly. Do not memorize. It will be in your minds forever. So this is the type, this is the prevalence, and these are the common symptoms. Again, the list continues. There is a Becker's, limb girdle, oculopharyngeal, and emeridrephis. So these are the various things. You find that progressively, you find that they are rarer in incidence. Now coming to our topic as such, what are the indications for a muscle biopsy? The indications will be, there is a progressive muscular weakness. The muscular weakness should be progressive. One day you are tired, you should not have a muscle biopsy. But when there is progressiveness in it, you will have to have a muscle biopsy done. Or when you suspect a neuromuscular disorder, again, this will be essential to make a definite diagnosis so as to give the supportive treatment, if not further development also. And also to confirm whether it is a necrotizing lesion, metabolic disorder, inflammatory, or a genetic disorder. In order to confirm this, you will have to have a biopsy to be done. So 1, it should be progressive, 2, it should be neuromuscular, 3, it should be necrotizing, 4, metabolic, inflammatory, or if there is any genetic abnormality. And what are all the investigations which should be doing? 1 is a clinical, 2 is electrodiagnostic, laboratory, molecular genetic testing, muscle biopsy, histochemistry, immunohistochemistry, and then genetic. Most indicated is the rapidly progressive muscular or neuromuscular disorder. And indications for the choice of site. You will have to identify a quantifiable amount of weakness, and that can be the site for biopsy. Secondly, please do realize that other less expensive tests may not throw more light. Therefore, a muscle biopsy will become mandatory. A serum molecular genetic testing in a case of dystrophinopathy can be done. And whenever there is a progressive weakness, you'll have to look for hypericemia. So here it is actually supposed to be CK. CK is creatinine kinase. And when we say creatinine kinase, it is isoenzyme in a case of muscular dystrophy. When there is a calf hypertrophy and a patient who is using a Gower's maneuver for standing. These all can be some indications. And choosing a muscle biopsy. Normally you find that these are the muscles of choice, the deltoid, the biceps, or the quadriceps. They say that deltoid is superior. The gastrocnemius and the tibialis anterior muscles are appropriate choices for the concerned diseases. Sometimes you find that peroneus brevis is also biopsied when a nerve pathology is suspected. Look at this one. I find that this is supposed to be an entire nerve bundle, but then there are only a few muscle fibers which are left behind, and predominantly it is being replaced by insinuating fat. Also, you find that there can be variation in the fiber size and rounding of the fibers, etc. This can be a classical example of an end-stage muscle. What are the IHC markers? Always, nowadays you find that whenever you open it, there is a panel of, or rather a plethora of marker for each and every condition. How can we remember? So I tried doing my best for you people. Remember 4 Ds: dystrophin, desmin, dystroglycan, dysferlin. 4 Ds. So sacroglycan, because sacra, that is supposed to be associated with muscle, and myo is also associated with muscle. So these, I think, we people can remember. The rest, if you can recollect, you are great. And this is a wonderful center and ancient picture of it, Nimans in Bangalore, that has done a remarkable service for neuromuscular disorders. And if at all we have got any such case, it is worth referring the patient or the biopsy to this center. And also you people can visit it during your life. It is one thing that we will have to pay regards to. Earlier I had mentioned another center for the autopsy procedures. The pathologist should be knowing. Nowadays we are getting request forms without anything. But in this particular case, or rather in anything, we should be getting the detail of the biopsy site. A complete medical history is needed. Clinical details such as the Gower sign, etc. Is the weakness progressive, so on and so forth. What is the clinico-pathological correlation? And secondly, what is the clinician-pathologist correlation? These are two different things. Clinico-pathological correlation is something that is the development of a disease. This will be a kind of agreement between personalities where we always tend to disagree. Again, a wheelchair as such, this picture will be talking millions of words. Hope is being able to see that there is light despite all of the darkness. Sometimes you find such sayings are all wonderful. What is the procedure of a biopsy? You people will be knowing about bone marrow aspiration, bone marrow biopsy, etc. This is almost similar. The limb is affected. Whichever is affected is inspected. And then you find out or localize a site. The pulses will have to be palpated. You will have to avoid them. The skin is cleansed and betadine applied. Local anesthetic should be avoided penetrating the muscle. Any of these should not be penetrating the muscle. There should be a clear line of incision that is shown over here. And you find that the skin is being separated, the fascia is being teased out, and the muscle is being exposed. Also, I am having a couple of nylon fibers will be helping me in elevating the muscle so that it is being cut. So the facial layer, and then there is a blunt dissection, separation of the muscle fibers, the muscle is excised. And just like any other surgery, there is a closure of the fascia, and then there is a closure of the skin as such. This is done. And look at this instrument over here. They have got a beautiful pair of, I won't call them forceps or anything, scoop, that is helping them remove the muscle without any trauma as such. They say that once you people remove, it is better that it goes into the container. Sometimes we have been advised to tie the muscle onto a pair of sticks so that it remains as it is and does not develop any contracture during the processing. We are not supposed to hold it in forceps and cause a second contraction. Needle biopsy is another procedure. So this is strange. So it has to be a minimal incision of about 5 to 10 millimeters. That is the incision. You open it, and then there is a needle called as Bergstrom needle. Probably these are those. And 100 milligram will be adequate for immunohistochemistry and biochemistry. There can be some limitations of it. One, we can be missing the pathological site. Secondly, bleeding. Bleeding is of course common, but then missing the pathological site can be disastrous. The transport can be Shipping is a common word that is being used nowadays. I'll tell you why. And then for biochemical, you'll have to send it in a separate container. And then for electron microscopy, it has to be sent along with 4% glutaraldehyde. This is supposed to be a gastrocnemius muscle. In fact, I am seeing only 2 of the muscle fibers. There is some amount of fibrosis over here, and there is a lot of insinuating fat that is surrounding the muscle. So this is what shipping is meant about. What are the different techniques for muscle biopsy? Whenever you people talk about muscle biopsy, please remember the techniques. One is frozen section, 2 is paraffin section. And what it can be used for. Enzyme histochemistry, it can be used for. And you will have to immediately wrap it up in a gauze and then send it to the concerned laboratory. Paraffin, whenever you want to study the inflammatory morphology, etc. Again, it has to be wrapped up and sent. Electron microscopy, whenever you want to study the mitochondria or any kind of ultrastructural analysis, you can be doing this. The fixative is 4% glutaraldehyde. And biochemical, for assessing the storage and the mitochondrial diseases. This is the volume that is required. Rapid freezing with liquid nitrogen can be required. And serum creatinine kinase can also be helpful. ATPase. See, whenever I talk about a muscle biopsy, there is a biochemistry, there is a histochemistry, there is an immunohistochemistry. 3 things are there. And let us come to the histochemistry. That is because of the analysis of the enzyme ATPase, which is essential for the assessment of the fibers. In this one, I am finding a dark black fiber, a dark brown fiber, and then a pale pinkish brown, whatever it is. I am finding 3 kinds of these fibers. And these can be used with this kind of immunohistochemical markers and then confirm. So this again is essential. I had explained this in the earlier picture also or another class. Always when there is going to be a denervation and a reinnervation, there will be a clubbing of the fibers with a similar histological, histochemical, and a immunohistochemical morphology. So the ATPase will be useful for us in differentiating the fibers. Look again, 1, 2, and 3. That is 2A and 2C fibers are over there. So also over here. In this, probably there is some amount of regeneration or grouping of the fibers are present. It is better that we design our own checklist. This is something that I had done. I am not a very profile person in this, but then look for a clinical history, ask for a family history, a clinical examination of the patient. Any special signs or symptoms? Is he having a respiratory distress? Staging. What is the role of the neurologist? What is the biopsy intended for us to look into? A biochemical picture as such. Histological, immunohistochemical. Look for hypertrophy, atrophy, inflammation, angulation, target cells, fibrosis, fatty change, necrosis. So this is almost a near normal one. I am finding polygonal or hexagonal fibers with very delicate septae over here, peripheral nucleus, hardly any inflammation or fatty insinuation. That is why it is a normal fiber. There are 2 things. As I told you, it can be a enzyme histochemistry. So you study the enzyme ATPase, and I find that there is a different nature of each of the fiber which could be identified by means of this ATPase, which is not seen in the earlier picture. And later on, when I do an IHC, there can be either a fluorescent color because I need to identify it further. So this can be used. In this one, I am finding that there is a kind of differences in the fibers which could be identified. So histochemistry is different from immunohistochemistry. This is, forget all the other things that I have told you people and just listen to this. You find that there is a group of people who are the pillars of this process. There is a neuromuscular staff, which means a neurologist, a surgeon, a radiologist, the laboratory, that is a pathologist also included, and then whoever is going to give the therapy. And they all try to address the patient as a whole. And with minimal invasive confirmatory exams, they are not able to make any diagnosis. Then they are able to proceed to the muscle biopsy, because you are not able to get any conclusive result as such with all the previous things. So do a muscle biopsy. As I told you people earlier, glutaraldehyde, go in for electron microscopy. Nitrogen or frozen muscle biopsy, you people can go in for a histochemistry or an immunohistochemistry. Paraffin block for the normal histology as such. And sometimes you can study the mitochondrial respiratory chain also. As I had been mentioning in another class also, you find that the MRI will be able to tell us the distribution, the size, and the nature of it. The electron microscopy, it shows some kind of a degeneration towards the center. And this is again a slide that is showing central pallor over here, which we call as targetoid lesions. Targetoid lesions are common in muscular dystrophies. And this again will be of great importance. The topic is a little complex and dry, but then let us try to follow this one. Whether the patient is having a myopathy or a neurogenic disorder, that has to be confirmed. Once it is a myopathic one, these things will have to be followed. Is it a myopathy with inflammation or without inflammation? Is it acute or is it chronic? Or when I do a biopsy, am I going to see any kind of inclusions? And are there only atrophic changes? Or is the biopsy going to show me a normal muscle? This is what the biopsy part of it. On the clinical side, again the same thing. Is it inflammatory or the inflammation is missing? Is there something else toxic that is over there leading to a dystrophy? Is there any family history? Is it of an acute duration or a long duration? And finally, is there any exposure to drugs, which are all important? And whenever a biopsy is being done, is the affected muscle being biopsied correctly? This is what the clinician should be looking into. This is what the pathologist should be looking into. And only when there is a congenial correlation between these two will it be a success. So there are destructive morphologies, non-destructive morphologies, and inflammatory morphologies. I would like you people to kindly see this one. So in this destructive, there is an effacement of architecture, and here the architecture is fairly well preserved. Fibers can be of varying size. There is a moderate or mild variation. Internalization of the nuclei. That is because the muscle fibers, when they are younger, they will be having central nucleus. Necrosis obviously when there is a destruction. Phagocytosis again when there is a destruction. Non-destructive means there can be angulation because of the atrophy. Fiber splitting can be looked for. At least these terms, if you people use, it will be more than enough. Try to look at the subheadings, and that will be leading us to the answer more than enough for the examination. You are not going to become a neuromuscular pathologist with this. As I come to the end of the class, a couple of motivations for us. Do not judge me by my success. Judge me by how many times I fell down and got back up again. Nelson Mandela, a wonderful personality to be appreciated. And also this, I hope you people know this particular scene. It is from a movie, In Pursuit of Happiness. I had already explained to you once, but then there is always a happiness in serving my students. Thank you.